I'll introduce myself. So I'm Joe Monsius. I'm a radiation oncologist here at Dana-Farber and Brigham and Women's. Where Will Nagwa, who I think is the organizer of this course, is also a principal investigator in a lab here. And he asked me to talk about specifically stereotactic body radiation therapy in the care of patients with pancreatic ductal adenocarcinoma. So if at any point people want to know something else about pancreatic cancer with regards to radiation or otherwise, just stop me. But I was told this is specifically a course about SBRT, so I'm going to focus very specifically on that.
Yeah.
All right, so let's get going. And also stop me at any point if anything on the slides you have questions and whatnot. And so no disclosures here. So we're going to jump right into unresectable pancreatic ductal adenocarcinoma, where there's been the most work on stereotactic body radiation therapy, and probably if there was an indication for SBRT, this is probably the one where there's most active investigation going on. So I'll give that as actually a disclaimer for the whole talk. Unlike, I believe you've already had lectures on SBRT for early stage lung cancers, where there is very good evidence and a good track record of success in SBRT in that situation. In pancreatic cancer, I would classify this as an area of active investigation where we really don't know what the right regimen is, what the right dose is, what the right situation is to use SBRT, or whether we should be even using radiation at all. So I would just remember that as we go throughout this entire presentation, and I'll re-emphasize that at the end, in that this is an active area of investigation where, even though I'm currently offering SBRT to patients, it's something that we have early phase clinical trials trying to figure out what the right way to do this, and even if it's the right thing to do. And I think you'll get a sense of that either from your already prior experience, but also some of the challenges that we have when we're doing SBRT for the pancreas. So I assume you guys are all familiar with pancreatic ductal adenocarcinoma, and it's a devastating disease, very hard to diagnose. When it's diagnosed, most patients present with either metastatic or locally unresectable disease. There is a spectrum of those patients that present with localized disease from resectable to unresectable that has to do with the arterial and venous involvement. And there's a nice basically review article in the New England Journal that talks a little bit and gives this nice spectrum of resectable to unresectable with regards to involvement of the portal or superior mesenteric vein versus encasement versus arterial involvement versus arterial encasement. And as you move further along this spectrum, you become more and more unresectable. So when we're talking about unresectable pancreatic ductal adenocarcinoma, here it's usually meaning unreconstructible vein involvement greater than 180 degrees of the SMA or celiac. This is pretty rare aortic invasion, and obviously metastasis to lymph nodes beyond the field of a traditional resection. So these are just a couple images of such a situation. This patient has a pancreatic body tumor that is encasing the celiac trunk with the common hepatic, and not so important that the splenic artery also encased. Situation of, this is probably an uncinate process lesion where you have the superior mesenteric artery coming off. You can see that encased, and also here, superior mesenteric artery. Because this is a situation that, even if the patient's had chemotherapy, this is not a patient where you think we can safely take them to the operating room in order to get an R0 resection. Here's another tumor where there's, again, further invasion, whether this is the celiac or the SMA. I guess this is actually showing a picture of the pancreatic ductal. So why would we think about radiation for a patient with unresectable pancreatic cancer when we know this disease has a very, very high rate of metastatic spread to the liver and peritoneum? It's because there have been studies presented looking at patients with unresectable disease, and many of them will die of metastatic disease, but there is a proportion who will die of their local progression. And so because they can't do surgery in this situation, you know, what's the other one local treatment that we have that has the most track record is radiation therapy. And so, you know, the thought has been, and there's been a lot of investigation as to whether or not radiation therapy can be helpful for, you know, local control. And so we'll get into a little bit of the evidence to set the stage for, you know, what are the active investigations with different types of SBRT. But that would be the rationale, is that if we can provide some local control, that might provide symptomatic benefit for patients, but also potentially progression-free survival or overall survival. So this has been studied for a long time. This is an ancient, I would consider, historic trial at this point, but this is a GITSG trial looking at patients with unresectable pancreatic ductal adenocarcinoma receiving radiation plus or minus chemotherapy. You can see that you know, there's really not too much to say here, given that this is an ancient study, but even in early attempts to dose escalate the radiation, you really don't see much benefit. And there's so many caveats here, and if you look at the year that this is published, and that likely this is a split course of radiation, but suffice it to say, it's been a long time that people have been studying radiation for pancreatic cancer without much benefit for multiple different things tried. So this is a more recent trial from the ECOG cooperative group, where they're looking at, so after multiple studies with chemotherapy, it was clear that there was a benefit to chemotherapy for patients with unresectable pancreatic cancer, as shown in patients with metastatic disease. And it was clear that trying to select the patients that most would benefit from local control would be a good idea, such that they should have some amount of chemotherapy before having radiation therapy. So that's what this trial is set up to test. It was a phase 3 trial where patients would have, at the time, the state-of-the-art chemotherapy, which is gemcitabine, followed by either additional chemotherapy or to a course of chemoradiation, then followed by chemotherapy. This trial closed very early, so it did not meet its accrual. It was not powered to look at overall survival. But that being said, you know, at least with the patients that were enrolled, it did look to be some at least minimal improvement in overall survival, but with a large amount of toxicity. The trial that you do need to know that was enrolled appropriately and it was powered to look at overall survival was the LAPO-7 trial, which again, same design, basically chemotherapy alone, and then either no more treatment or chemoradiation. And here there was, you know, a large number of patients enrolled, almost 400, and there was no improvement in overall survival, no improvement in progression-free survival, but the authors did note a slight improvement in the patients that received radiation therapy in terms of their local progression was significantly less than that with chemotherapy. So right now, this is the only, you know, this is a phase 3 trial that most medical oncologists and many radiation oncologists point to, that at least with chemoradiation at the doses that they were using here, which was 54 gray and 1.8 gray per fraction, there's really, you can't really offer patients an overall survival benefit based on this trial. So, you know, as we just said, adding chemoradiation is not superior to continuing chemotherapy for locally advanced pancreatic cancer. There was some part about erlotinib in there, and then adding chemoradiation does improve local control. So there have been many other studies. I think suffice it to say, you know, this LAPO-7 one is one that you should know. and that there was really no improvement in overall survival. So a lot of people have asked, well, we've had great results in other diseases such as liver cancers and lung cancers with SBRT. What about SBRT for locally advanced disease? And so this started almost 2 decades ago, asking the question as to whether or not you could use similar doses of SBRT as had been tried in lung cancers. And so I'm not presenting them, but some of the early studies of SBRT in pancreatic cancer were using things like 45 gray and 3 fractions. And the early experience is that it wasn't as easy as was demonstrated in lung cancer, in that there was significant amount of toxicity without necessarily significant gains compared to what was presented in the LAP-07 trial. So there was a course correction initially from these higher dose regimens that were along the lines of lung cancer down to a much lower dose regimen, which we'll talk about, is basically 33 gray in 5 fractions. That if you believe, biologically effective dose calculations would be around what a 50.4 gray and 1.8 gray per fraction would be equivalent to, with the idea that, well, we can't escalate the dose safely here, but at least we could give it in a shorter amount of time and maybe we'll get the same effects of the local control. The critiques of SBRT that still hold true today is that it's never been compared to conventional chemoradiation in a randomized trial. And critically, the margins are very tight. And because, as we'll get into looking at some of the images, and as you guys are aware, many of these tumors are very close to the stomach and the small bowel, and those are radiosensitive organs, especially to high dose per fraction radiation. And so parts of the tumor need to be undercovered in order to make sure that you spare the patient's potential ulceration. And so, with using SBRT with tight margins and sparing parts of the duodenum, at least with the 5 fraction regimen, we're going to be under-treating parts of the tumor that are next to the bowel and the stomach. And as I just mentioned, the BED of this 6.6 gray times 5 is about comparable to the 50.4 gray in 28 fractions that I just mentioned. So we'll get into this. Yes, go ahead.
Yes. So can you actually call it SBRT? But because according to one school of thought, if you're not giving more than 100 gray BED, it's not SBRT. Would you believe that, or do you agree with that?
Yeah, I completely agree. I mean, so yeah, what the definition of SBRT is I guess is under debate. But people have called this SBRT, even its low dose. I would call it low dose SBRT or hypofractionated radiation therapy, or hypofractionated radiation therapy with an SBRT setup. But you're right, I wouldn't call it ablative dose radiation therapy, or some people have called SBRT stereotactic ablative body radiation therapy. So I would definitely not call it that right now when it's 6.6 gray times 5. And what we're going to get into, to your point, is that we know, I guess, based on other diseases, including in the liver and the lung, is that you really need to get, as you just said, to a BED over 100 in order to actually call it, or hope that you're going to be having ablative capabilities. And that's what's actively being tested in pancreatic cancer, which we'll get to. I think it's probably useful, though, to sort of set the stage as to what has come before in terms of, and what are some of the technical limitations right now that, at least in my opinion, don't allow safe dose escalation with the current, just standard setup of cone CT on a standard, LINAC. And why, at least at our center, we require something like better onboard imaging, like an MR-based LINAC, or in other centers they have CT on rails or some better way that we can really account for the location of the tumor and especially the normal organs in order to get to that ablative dose. So whether or not you call it SBRT or whatnot, you know, I think as long as you're defining what dose you're using, people can understand that this is not an ablative dose when you're talking about 6.6 gray times 5. But the literature is replete with people calling this SBRT. So, you know, I think I'll classify it when I talk throughout, you know, what doses we're talking about, so you guys can make the judgment as to whether or not, you know, that's an ablative dose or not. So I won't go through this in great detail. This is a slide I made for medical oncologists, just as the alphabet soup of the different types of radiation therapy that we deliver. And I guess I leave it in here as, I guess, a reminder that when you're talking to your colleagues in surgery or in medical oncology, to make sure that you remember that we've made this extremely complicated, and to try to make sure that you get them on the same page as to what you're doing. And as you just rightly pointed out, you know, when they hear SBRT, they think lung SBRT, but actually, you know, we're not really delivering those ablative doses of Pancreas SBRT. So maybe calling it something else, or very much specifying and getting them to understand, you know, that dose matters with regards to the biological outcome. So this is also geared more towards actually gastroenterologists and medical oncologists, because you know, it has been the case that we've needed fiducial placement for even low-dose Pancreas SBRT to make sure that we're in the right spot. And so this was basically just I put together an evolution of image-guided radiation therapy, just to remind us sort of where we came from and where we're headed, and that we really started with tattoos and light fields and portal imaging, and that the era of 2D, 3D radiation therapy with this RTOG 9704 for adjuvant pancreas was really based on bony landmarks, and that we've now moved to, you know, contouring atlases based on CT-based anatomy, and that allow for, you know, intensity modulated radiation therapy plans. And so you guys can tell me to skip over this at any point if you want, but I also put this together so that again, people outside of radiation oncology can understand sort of the differences in the workflow for a conventional fractionation workflow versus SBRT. And so this is basically just sort of similar to what we do here now, in that mapping, volume delineation, evaluation with medical dosimetry, plan review, quality assurance, and beginning treatment, and daily KV images. And then this is an example of, on a clinical trial here, what the recommendations were for contouring for a conventionally fractionated radiation therapy plan. So I basically drew that out, and then we'll be able to do a side-by-side comparison with what a trial recommended for contouring for an SBRT case, which I also drew on the same patient. And so there's a pancreatic head tumor here. What they recommended here is that the SMA be contoured as well as the celiac artery, and then these various expansions be made. So you can see that the volume is quite large, and that even CTV overlaps some of the nearby bowel as well. And so, you know, as you'll see later on when we look at the comparative SBRT contours, that, you know, they're much tighter, and you know, you have to think about whether or not that's the right thing to be doing for patients. And I'll talk a little bit about how some people have tried to get to ablative doses by not necessarily doing it in a 5-fraction regimen, but in a 15 to 25 fraction regimen, where you can get a true CTV margin that might account for, you know, microscopic extension of the tumor. So this, again, this was for an audience not familiar with SBRT, but you know, SBRT, as you guys know, is not truly a stereotactic. And, you know, the definition actually from at least the American College of Radiology and the American Society of Radiation Oncology it's not specific, so it doesn't get into that ablative aspect of it. The quote is, at least from the version that I was looking at, stereotactic body radiation therapy is an external beam radiation therapy method that very precisely delivers a high dose, not specified here, of radiation to an extracranial target. There's a billing aspect to this here, at least, that it has to be 5 fractions or less in order to be called SBRT. There's a wide variation, and they will allow it to be called SBRT, with a wide variation of doses from 5 to 34 gray per fraction. The Alliance trial, which I'll talk a little bit later, as I mentioned, was 6.6 gray times 5 fractions, 33 gray, versus many lung cases are 18 to 20 gray and times 3 fractions. So what are some of the challenges with pancreas SBRT? So the pancreas can move, and I'll show an example of a study of that. So what are ways that we can address that? Either abdominal compression, breath hold. You can think about tracking if you have that on, say, a Cyberknife system. Finding the pancreas tumor or where your target is can be quite difficult with cone beam CT. And so, as you'll see in following slides, our solution to date has been using fiducials or even a biliary stent in order to actually be able to see where the tumor is on a cone beam CT. Another challenge is obviously the organs at risk, which I can't stress enough how important it is that we account for these. And if you can't account for them, you can't see them, and we really shouldn't be trying to push the dose too much. Many times I get asked the question about, well, Cyberknife sounds way better than, or proton beam sounds way better. And this is just a slide that I put together, again, for non-radiation oncology audience, just to remind people that it's all radiation and they all have advantages and disadvantages. Obviously, LINAC-based SBRT is the most common form of radiation therapy, and it's readily available. Have the best onboard imaging capabilities compared to these two. This slide has to be updated with the MR-guided radiation therapy that's now becoming available, which we'll get into at the end of the lecture. So this is just an SBRT workflow. So if a patient were receiving FOLFIRINOX chemotherapy or gemcitabine and Abraxane chemotherapy, and they were nearing the end of their course, and we felt that they had, still localized disease. Currently, if they don't have a biliary stent, we do need EUS-guided fiducial placement, so that usually has to be done. I like it at least 5 to 7 days before the mapping in order to make sure that the fiducials themselves aren't going to move from the time when they're placed to the time of the simulation. So at the time when I made this slide, we were exclusively using abdominal compression. We also now have the ability for a light inspiration breath hold. But obviously immobilization is going to be important in either setup. Volume delineation, which we'll get into a little bit, and then working with your medical dosimeters plan review and beginning treatment with the daily cone beam CT aligning to fiducials, or in this case, a stent. So there are many studies out there, retrospective, looking at outcomes of series of patients with either unresectable or borderline resectable pancreatic cancer. There are many different fractionation regimens. I think that it creates quite a quagmire for, as to what's the right thing to do in this situation where all the evidence is basically retrospective. I mean, there are a few phase 2 trials showing safety of a 33 gray in 5 fraction regimen, but it's really all over the map, using 3 fraction regimens, 5 fraction regimens, up to 40 gray with an integrated boost to the tumor vessel interface. So every center has their own little flavor of this, and it actually is a little bit maddening that we haven't gotten together as of yet as a field in order to really test, this compared to a long course chemoradiation, or test it compared to a 15 to 25 fraction dose-escalated fractionation. So, I'll give what we do at our center, but that's not to say that that's the only way that people are doing it, and it's not to say that it's the right way. So, I'd be open to hear what other people's experience are at their centers, but, there's a vast amount of literature using SBRT for pancreatic cancer, and I think we can say a non-ablative dose regimen is relatively safe, and that at least in the series that are published, it seems to be somewhat effective in terms of local control, but I don't know if we can really say that, with confidence compared to a chemoradiation that was done on, say, LAP-07, because it hasn't been compared head-to-head, but at least retrospectively, it appears to be about the same, at least with the non-ablative SBRT regimen. So this was basically a trial looking in borderline resectable pancreatic cancer as to whether or not it's the right thing to include SBRT before surgery. I think in the setting of borderline resectable pancreatic cancer, it's on this with current FOLFIRINOX-based regimens. We don't have any real great data to say that we should absolutely be doing radiation before surgery. And I think it's, again, on a center-by-center basis as to whether or not people are including radiation before surgery. Now, I know that there are phase 3 trials, one that hasn't been published yet, but has been presented, the pre-op panc, where they're using some type of chemoradiation in these borderline resectable patients before surgery, but that trial, as it was presented with gemcitabine alone, it's not a current chemotherapy regimen. So I wouldn't, unless the patient's not a candidate for FOLFIRINOX chemotherapy, I wouldn't necessarily use that regimen and necessarily say that that is going to apply in the setting of FOLFIRINOX chemotherapy. So, I think our whether or not we should be using SBRT or radiation in general in patients with borderline resectable pancreatic cancer is also an active area of investigation, and it's not clear that you even need ablative radiation doses before a surgery, and whether or not that's safe. And so I think that you have to look at the evidence yourself. Well, again, I'll tell you what we do here, but I wouldn't say that there's any right answer right now for this setting for borderline resectable pancreatic cancer. I put it up here because we'll go through a little bit of, at least on this trial, what the recommendations were for contouring. But before that, we'll talk a little bit about some of the technical aspects of setup. So currently on a cone beam CT-based LINAC setup, you can see that the image on the right is just not high quality enough for us to be able to see where the small bowel, the stomach are, where the tumor is. And so we need some type of fiducial placement in order for us to actually lock onto with the cone beam CT. As you know, the soft tissues don't have great structures that you can use for tracking. In the Cyberknife system, they absolutely need fiducials. I was at another center before that had a Cyberknife, so I have experience there, and they use gold fiducials for their setup. So why do we need fiducials? Why can't we just align the bony anatomy? Here's one study that looked at interfractional position variation of pancreatic tumors. So what they did was they basically have fiducials implanted. They're doing daily cone beam CTs during radiation, and they're looking at the displacement of these markers relative to the bony anatomy. So they didn't feel like there was any marker migration as sort of measured by, relative position to each other. But in terms of if you just lined up to the bones, basically there can be greater than 10 millimeter vector displacement of these fiducials on any daily basis. So you really have to use the fiducial markers. You can't necessarily just line up to the bone and expect that the pancreas is going to be in the same location each day. And this is some of the actual data within this. So these are individual patients, and looking at, on a daily basis, the location of the fiducials relative to the bones in the left to right, sup-inf or ant-post directions, and then a vector overall. And you can see that there can be at least in this patient, up to 25 millimeter vector displacement. So that means if you were lining up to the bone, you'd be potentially off by 25 millimeters and aiming your radiation in the wrong place. So that's why we really have to use fiducials when you can't see the tumor well. There's also intrafraction movement with breathing. So this is a different study that looked at basically where the fiducials are during respiratory motion. So these are 11 different patients, and they're looking at, again, the different right, left, and post-supine displacements based on sort of normal breathing throughout the course of what would be a 1 hour treatment. And so you can see that if you don't account for this in either a ITV or try and minimize the breathing, that if you have a very, very tight field and you're aiming at one place, the tumor may only be in that area for one spot. And I think you guys are probably very familiar with this concept from lung SBRT as well. So what can you do to minimize this motion? And again, similar to lung SBRT, you can think about respiratory motion tracking, gating systems, abdominal compression. So this is, again, just a little bit more about why we need the fiducials. And these are some very strict requirements that at least the company that makes the Cyberknife puts out. I would say that it's a little overkill for a LINAC-based, traditional LINAC-based cone beam CT. Our standard here is that we ask for at least 3 fiducials. 4 is great. Once they start placing 6 fiducials, here at least, they start to become quite clustered. And so it's actually sometimes defeats the purpose because some of the fiducials are too close to each other and you can't tell which one's which. It does help to have spacing. So when you talk to your gastroenterologist, if they're placing these fiducials via EUS, which is what I'd recommend as opposed to interventional radiology, having them spaced out is important, and emphasizing that they absolutely do not need to be in the tumor and they don't need to paint the borders of the tumor. These are common misconceptions that the gastroenterologist will have. It's okay that, if there's one fiducial in the middle of the tumor and then one fiducial that's just outside of the tumor. They don't need to paint the borders. You just need to have them spaced and hopefully, soup to inf and in different sort of aspects of one axial plane as well. This is just, you guys have these slides, but you can look through them. This is what one trial suggested in terms of placement of fiducials. This is a study that looked at, okay, so you have those strict requirements for ideal fiducial geometry. Does it really matter to get that ideal fiducial geometry? And basically, this one said that at least using a Cyberknife system, so the gastroenterologist placed the fiducials and only 18% of them had quote unquote ideal fiducial geometry. That being said, 90% of those patients, they could successfully track the fiducials. So I don't think we really need to be too strict about it, but some very basic principles. Try and have at least 3 fiducials, try and have them spaced out, and try and have them in different axial planes and a soup mention, and that will help with your guidance. So let's see. So then, some people ask, well, these fiducials are in there, do they interfere with your follow-up imaging? And so this is a study that looked at trying to use a spectral CT with metal artifacts reduction software in order to help with ongoing evaluation. You can see, at least in their hands, this is quite effective at minimizing the artifact. And so they concluded that, if you're able to use these different CT parameters afterwards, you can really minimize the artifact that you can see with these, so that you can still visualize the tumor. All right, so here's, as I mentioned, a side-by-side comparison of what a SBRT contours would look like compared to conventionally fractionated radiation. So this is the Alliance protocol, what they recommended for contouring. So there they recommend contouring the GTV, a tumor vessel interface, in essence an ITV, there's no CTV, and then they called it the PTV basically that ITV plus the tumor vessel interface plus 3 millimeters. And then they had multiple different PTVs. PTV1 was basically this ITV plus the tumor vessel interface plus 3 millimeters, and that gets 25 gray. And so that can even overlap with the duodenum or the stomach. And then they have a PTV2, which is, again, this same thing, but then a subtracting out of your basically GI structures that are your GI structures plus 3 millimeters. So that's basically editing out around where the bowel is. And then there was a final PTV3 that was the the tumor vessel interface plus 3 millimeters, and then also minus that GI PRV. So that's what we did for patients on this protocol, and we still do that for patients with borderline resectable pancreas tumors. If you think about it, for a patient with an unresectable tumor where there's really no hope of going to the OR safely, it doesn't really make a lot of sense to just boost one small part of the tumor. You should really, within the limits of what you're able to, safely do in terms of how accurately you think you are targeting the tumor and knowing where the organs are, you should try and boost the whole tumor to as high a dose as you think is safe at your center. So here, what we'll do is we'll contour out the entire tumor, the ITV. We'll also contour out the tumor vessel interface. And then we will basically say, let's try and get the highest dose to that, but still sparing the normal tissues. So we'll do that, and we'll basically subtract out, again, the 3 millimeters of expansion from the GI structures, or if we're trying to get to a higher dose, the 1 centimeter, if we're trying to get to 40 gray using the cone beam CT-based method, and say that we'll accept under coverage anywhere within 1 centimeter of the bowel, but try and get as much of the rest of the tumor to as high a dose as possible. And you'll see that's basically the paradigm that's being taken with the true dose escalation studies using MR-Linac, which we'll get into a little later. All right, and so this is just a comparison of what it would look like contouring-wise, conventional fractionation versus SBRT with the same patient. And this is just one example of an SBRT plan. With the volumetric arc-based plans, you can see that you can, get a perfect dose distribution, with your PTV1 and then your tumor vessel interface PTV, where you're going up to 40 gray. I think, this looks great on paper, but you have to remember that, at least with a cone beam based CT setup, I don't know how confident we should be that we're actually getting this 40 gray exactly where we want it. So you just have to think about that and be real careful about, where your bowel is, where your stomach is, if you're trying to escalate the dose. If I'm not clear about that at all, just stop me at any point and ask questions. So, go ahead.
So, can you go back?
Sure.
Yeah. So, when you talk about the dose distribution, when we talk about lung stereotactic body radiotherapy or ablative radiotherapy, the high dose area is in the middle of the tumor. So does that hold true in pancreatic cancer as well, or it will be homogeneous dose distribution?
So in terms of how you're normalizing and sort of and whatnot, these are fairly homogeneous plans with regards to these different PTVs. So this is the PTV2, which the dose to it is 33 gray. And you can see that it's, at least within this area, it's pretty uniform. So there's not like a dose gradient within this part of it. But on purpose, you can see that this tumor vessel interface, this PTV3, which is within the PTV2, which is going to 40 gray, is on purpose. So we're trying to, I guess if you want to think about it, trying to shift where the center of the high dose is to a specific spot So it is different from the lung-based SBRT, where you're not really trying to tell, the dose, the highest dose within the PTV to be shifted to one spot or the other. So it is unique in that way.
Okay. Yeah. Thank you.
Sure. So as you saw from the LAPO-7 trial with 54 gray and 1.8 gray per fraction, which is basically the 33 gray and 5 fractions, there's really not much benefit here, maybe some local control benefit. But what if, as you guys rightly pointed out, we were able to dose escalate safely? We know in liver SBRT we can have excellent control. There's some retrospective early studies that are a little hard to believe, but suggest that if you're getting above certain DEDs, this is still not even an ablative dose in patients with pancreas cancer, that maybe you could improve survival. I would really take these with a grain of salt, but this data is out there and has provided the impetus to study dose escalation in multiple different trials that are ongoing. This is a more recent study from multiple groups that have MR-guided radiation therapy, where again, they looked at patients separated into a high dose versus standard dose, that it wasn't planned that way, it was retrospective, and some centers were giving higher doses, some were giving standard doses, and they, at least again in this retrospective study, there's a suggestion that there's a benefit in the high dose cohort. So what's the issue with dose escalation? I think I've discussed this multiple times. Unlike in the lung and the liver, where it's a parallel organ that can tolerate high doses to a small volume, the duodenum and the stomach, they're serial structures, and they can tolerate low doses to the whole organ, but they cannot tolerate high doses to a small volume. And what happens in that situation, if you're delivering too high a dose to the duodenum or the stomach, is that you can cause ulcers that can be life-threatening. And so this is what happened when, without being able to see tumors early on in the SBRT days of pancreas cancer, giving 45 gray and 3 fractions, they saw, significant grade 4, I believe even grade 5 ulcerations. And so we have to be really thoughtful and careful here when we're thinking about dose escalating. So Chris Crane, who's a radiation oncologist at Memorial Sloan Kettering, basically puts forward this idea that you take what you can get with pancreas cancer when you're thinking about escalating the dose. And so the idea here, it's not a fantastic schema, but if this yellow thing is the tumor and it's abutting the duodenum, which is here in orange, that basically you do a dose gradient. And here he uses a 15 or 25 fraction regimen, where he gives a 45 gray CTV dose that can overlap with the duodenum, and then he gives shrinking parts or shrinking fields to stay off the duodenum, so a 75 gray field and a 100 gray field that basically, again, take what you can get. So, and that's the principle, whether or not you're doing it with 15 to 25 fractions or a 5 fraction, quote unquote, SBRT regimen. So what's the issue if you design a plan that you think you can get dose escalation in your bowels far away on your planning scan? As you all know, the bowel and the stomach can move on a daily basis. And this is just an MRI on one day, and you can see the small bowel moving close to the tumor. I think I'm more worried about the fixed duodenum and the stomach right next to a pancreatic head tumor. But this just illustrates the point that, if you make one plan, it's not necessarily what's going to be, the reality on day one of radiation. So as I've showed this picture before, but you really can't make out where the small bowel is on a cone beam based CT. So the solution, at least our solution is, and there are other ways to get around this. Other centers, such as at Sloan Kettering, Chris Crane has a CT on rails, so a diagnostic quality CT scan, where he feels that he can actually see where the tumor is, see where the normal structures are, and then make adjustments based on that. Our solution has been to basically use this now commercially available MR-guided radiation therapy setup, where you have an MRI in line with a linear accelerator, such that you can see, using MR, right before treatment and during treatment where the tumor is, and just as important, where the normal structures are. Has anybody presented the MR guided radiation therapy yet to you guys?
No, not as yet, but
Okay.
I think that is something which is coming up more with the abdominal radiotherapy now.
Great. All right.
Yeah.
Now, if you don't mind, I'll just show a few images just as an examples of you know, how this could improve not only for abdominal SBRT but for others. So you know, I'm not saying we're using SBRT for breast cancer here, but just as an example, with a CBCT versus the low field MRI, even with the 0.35 Tesla MRI, you can see, you know, the lumpectomy cavity much better. For prostate cancer, really can't see anything with the cone beam CT, but now you're getting the bladder, the prostate, the rectum quite well. In the setting of abdominal imaging here, at least with this liver tumor, I wouldn't say that all liver tumors light up this well without a contrast MRI, but here you're actually seeing where the tumor is. And then also thinking about on a day-to-day basis, not just lining up one day, but multiple days, and thinking about adapting the radiation plan. So this is a patient we actually did on our scanner. It's a healthy volunteer. And from day to day, you can see that the stomach especially, you know, there's a big bubble of air here, but on, you know, the next day it's completely, you know, moved if you're overlapping the contours. And so, and then in addition, seeing while we treat is important, especially when we're doing a breath hold situation. So this is a patient with the retroperitoneal tumor that they asked to basically hold their breath. And there's an imaging software that basically will identify this structure, and it will look for the overlap of that structure with your, in this case, looks like a GTB in red. And only when that, you know, structure that's being seen on the MRI lines up and is within you know, a certain cutoff as the beam on, and then when the patient lets their breath out, you can see here the target out will increase significantly, and the radiation beam should automatically shut off. So we can think about using this for pancreas SBRT, and this is just, you know, a slide saying, you know, what we do, what we currently do, and will continue to do. And then what we might be able to do going forward with these MR guided radiation therapy. So that, you know, we're excited about this. We're opening this in the next month. And this is going to be critical for 2 of the trials that I'll discuss with dose escalation pancreatic SBRT. So a lot of different sites can be treated with the MR guided radiation therapy. Basically anything you treat on a cone beam CT based linear accelerator, you can treat on this one. So how does this apply to pancreas cancer? So as I've mentioned many times throughout the lecture, you really can't see what's what. And my opinion is that we really shouldn't be doing dose escalation on a cone beam CT based setup for pancreas cancer, because you have to use fiducials. You can't see where the normal structures are. You can't adjust the plan on a daily basis. And so keep the radiation dose low here. It is a non-ablative dose level. And the idea here is that you might get the radiation done faster than you would get it done with a 30 fraction chemoradiation course. What's the potential future? Using MR guidance, so you no longer need the fiducials. You can see where the tumor is. You can see where the normal structures are, so that you could potentially adapt the plan on a daily basis. And this is just, it's not as pretty as that retroperitoneal tumor, but you should be able to, on a sagittal slice, which is all they have available for the real-time tracking, see where the head of the pancreas tumor is and try and follow that. And so, as I mentioned, adapting the plan is going to be critical for these abdominal SBRT plans, especially pancreas cancer. So if this is an original plan, and then they come on the day of treatment, and you can see that the small bowel has shifted or the tumor has shifted. And if you were to deliver that same high dose radiation to this area, you'd basically be delivering, if you're thinking about a 10 gray times 5, you'd be delivering 10 gray right to this bowel here. So the idea is that with the on-table image, you could adapt the treatment, push the high dose radiation away from this piece of bowel, still deliver hopefully ablative dose to the tumor. Because we don't know if dose escalation is the right thing for these patients, I personally think that this should be tested in the setting of a clinical trial. And so the manufacturer of the MR-guided linear accelerator that we are opening here has a sponsored trial available where they're basically taking patients with either locally advanced or borderline resectable cancer that have had chemotherapy. So you make sure that you select for patients that may potentially benefit from the local control. And the treatment is basically 50 gray and 5 fractions using this stereotactic MR-guided on-table adaptive radiation therapy, or SMART. And so we're excited to open that trial to try and contribute to data that will show that this is, one, safe first off, and two, what's the efficacy of it from a local control perspective, but also potentially progression-free survival and overall survival. Another trial that we're opening here is basically the same thing, except adding in a radio-protecting agent because, getting these high doses close to the bowel, it's still risky. And so, what could we do in order to protect the bowel even further? And this is just one example where they require endoscopy before treatment and after treatment, just to really assess whether or not there's any toxicity there. At least in this one patient, it looked like the duodenum looked pretty good, even despite the high dose radiation being quite close to it. Another trial that will open here is trying to radiosensitize the pancreas tumor using a gadolinium-based radiosensitizing nanoparticle. So details aren't important, but suffice it to say there's many ongoing trials looking at pancreas SBRT, dose escalating, radiosensitizing agents, radioprotecting agents, to try and find anything that's going to be helpful for these patients, because as you all know, the dismal prognosis. So I've talked about a lot of things. I'll just show you what we do here for patients with locally unresectable, locally advanced unresectable pancreatic cancer. So we always start with chemotherapy for those patients that are candidates for it, and at least right now, we always that usually is for good performance status patients, FOLFIRINOX chemotherapy, modified FOLFIRINOX chemotherapy. So that would be a standard of care initiation approach versus clinical trial options. All patients should be offered a clinical trial because the current standard of care is really not that great. And so one trial that we have available is testing combinations of losartan and immunotherapy, FOLFIRINOX and SBRT. So always think about what clinical trials you have available for these unresectable patients. I will say that there aren't that many clinical trials for this group of patients, but hopefully there'll be more and more. So the standard sort of workflow we have for these patients is chemotherapy for about 6 months, which is pretty much what patients can tolerate, whether it's Gemabraxane or FOLFIRINOX. Usually by 6 months, they're getting pretty tired and they need a break. So that's when we have a discussion about continuing chemotherapy versus taking a break versus considering radiation therapy for local control. There continues to be, based on the LAPO7 data, a resistance by some medical oncologists to even consider radiation therapy for at least the local control benefit. And I wouldn't say that's unreasonable, because there is some toxicity from chemoradiation or SBRT. But here we do try and at least see the patients and talk to them about what the potential benefit of radiation therapy could be. And off trial, we offer them SBRT between 33 and 40 gray and 5 fractions. We reserve the 40 gray doses to those patients' tumors, usually that are in the body, that are further away from the head of the pancreas and that aren't close to the duodenum and the stomach as much, where we think that we can safely, using a cone beam CT-based setup, see where the tumor is and know that the bowel is going to be away from where the tumor is, or chemoradiation. So I would say that Chris Crane has a good rule of thumb. If your tumor is basically the diameter of it is at least within 50% contact of the small bowel or the stomach, you probably don't necessarily want to think about a 5-fraction SBRT regimen or even a 25-fraction dose-escalated regimen, because to protect the bowel and the stomach, you're going to have to limit the dose so much around that 50% of diameter that's in contact with the bowel that it's not necessarily going to be worth the potential risk of toxicity. So we're really looking at that interface, how much interface there is with the bowel and the stomach is critical as to whether or not you think this patient would be a good candidate for SBRT. As I mentioned, we have these trials that we're opening up for patients with locally advanced pancreatic cancer, testing whether or not dose escalation is safe and whether or not it's the right thing to be offering these patients. So with that, that's basically the conclusions that I mentioned. What questions can I answer?
So I have one question. So what is the maximum dose of hypofractionation / SBRT that you have used so far in pancreatic cancers?
So me personally, it would be 40 gray and 5 fractions. And so there have been other people that have reported that, you know, as a safe regimen to do, but that's again for a highly selected patient population where the tumor is at least 5 millimeters away from any nearby bowel. And so that's what I'm comfortable doing on a cone beam CT based setup. And so it's really a rare patient that has that situation. I think with the MR guided radiation therapy, again, on a clinical trial basis, I'm going to be comfortable doing 50 gray and 5 fractions, even to a pancreatic head tumor if there isn't too much interface with the bowel.
Okay, and because we are just starting SBRT and there's no survival benefit of SBRT or hypofractionated radiotherapy so far, would you recommend doing SBRT in pancreatic cancer for a center who's just starting or initiating the SBRT service?
I think that, you know, the one benefit that I could really say for it is that it's, you know, shorter than a long course of chemo radiation. That being said, I think if you're just starting it, really trying to learn from another center what their experience has been is going to be important so that you can make sure that you're confident that you have all the team together that you feel like you need in order to provide as accurate targeting as possible. And so that really is the collaboration with your endoscopist. If they're doing core biopsies via US, then they should be able to do fiducial placement. What I would say, and this is again really Chris Crane, who's sort of one of the, I guess, leaders in this field, is that there's nothing magic about a 5 fraction SBRT regimen. I think because we've started it, the medical oncologists are really excited that it's short. But you know what I've recommended in my satellite center here, you know, basically in the Boston area, is that, and this is what Chris Crane would say as well, is that if you're not sure, I think doing something like 35 gray in 14 fractions, or 30 gray in 10 fractions, or even 36 gray and 12 fractions to offer a little bit of dose escalation is just fine. I mean, if you do the BEDs, like it's going to be about the same as 6.6 gray times 5. So I think what starts to happen and the risk that you run when you're trying to do a 5 fraction regimen is putting a hole in the bowel. And really, we don't want to do that. As you mentioned, there's no survival benefit here. So, you know, potentially putting those patients at risk when you really don't see that happen that often in the long course chemoradiation or with 30 gray and 10 fractions. I think if and honestly, my center itself, I am going to be looking at whether or not, especially for borderline resectable patients, whether we should be doing a 5 fraction regimen at all, or if we should really just be moving to 30 gray and in 10 fractions preoperatively, which is what MD Anderson has done for a long time as well. So I don't think that you are, if you don't offer it, I don't think it's something like you have to feel I'm not offering something that is a real potential benefit for patients. And so if it were me and I didn't have a lot of experience in another center, I know there's a desire to want to offer the latest, greatest, but I wouldn't necessarily call this the greatest.
Yeah,
So
exactly.
I wouldn't feel I hope you got the sense from my lecture that we really don't know what we're doing here. I mean, we know what we're doing technically, but we really don't have great evidence to say that this is the right thing to do. I think we've got a lot of work to do in order to really sort this out as to, one, whether radiation is even the right thing to do, and two, if it is, what the right type of radiation is. So
yes, I completely agree. Yes, we do. Because this is one area where I think the SBRT is still, we need to be sure about what we are doing.
Yeah. Yeah, and I don't mean to be pessimistic about it, but I just want to be realistic about it. And that, you know,
yes,
what happens here is that, you know, people need to study something, and so they're like, well, SBRT seems to work in these other places. We need to study it in pancreas cancer, and we go for it. And it's frustrating from my perspective that I mainly run a research lab, and you're able to you know, as best as possible control our experiments. But what happens a lot in radiation oncology is that everyone publishes these retrospective studies, and we don't do, you know, the randomized study that we need to do in order to understand, is this better than chemoradiation? What group of patients is it going to benefit? And we get this situation where I've been at meetings where the medical oncologists get up, the surgeons get up, and they say, like, what are you guys doing? You guys are all over the place with your doses, the number of fractions that you're doing. And I tend to agree. And so, you know, what do we do about that? I mean, I think that some of these dose escalation trials are a step in the right direction to try and get multiple groups together to understand what the right situation is to use it, whether or not this is safe. But until, you know, we sort this out as a field, I don't think it's wrong to not offer this. And I think, you know, a chemoradiation course, while it's a long treatment, is a totally reasonable option, as is 30 gray and 10 fractions.
yeah.
Hi, I have a question. Going back to the MR-based clinic, you talked about that software that tracks tissue. Is it similar to something like the LOT in Cyberknife?
Oh, so the last time I used the Cyberknife was like 2016, and what I remember there is that they are basically creating a model based on the breathing and the fiducials, and they're taking images, you know, every.
That was actually, you didn't need fiducials for that, so it was just tissue tracking. So you could do like 1 image, 2 image, or no image. So you would just.
Yeah. So
So
in some ways it's like that, but in some ways it's a little bit better. So, you know, whether it's fiducial or not in the Cyberknife system, they're not taking a continuous image. They're basically taking images every, say, 5 or 10 seconds, and then they're using the breathing trace, and they're creating this model of where they expect just the tumor to be at any one time throughout the breathing cycle, and they're moving the radiation system based on that model that they've created. Here, what we have here, I'll just bring it up again, is that this is a real-time continuous image, such that it's on the image is being taken the entire time the patient is having the treatment. So there's no model that you need to create. You see what you treat. And so this patient is holding their breath, and the only thing that is being calculated is how much of this black blob here that the system is automatically detecting because you told it to look for this, how much of that outlined in the green is within this red area, which is where the radiation is pointed in order to deliver the highest dose. So I would say it's very different in that it's a real-time continuous image that is you know, looking specifically at what we're treating.
okay, that's good. And that software is on the Linux, basically, like on the MR. Yeah.
Exactly. So this is the, you know, I don't have any financial stake in this, but this is the MRIdian system from ViewRay. There's another one from Electa, and the software is all built into the treatment delivery system.
Okay. Thank you.
I have a question. What are the criteria for the patient choice other than the site of tumor?
Criteria for?
Choice of patient. What kind of patients we use for SBRT in pancreas?
So in my center, we still offer SBRT for patients with borderline resectable tumors where there's continued involvement of vascular structures even after chemotherapy. And so we'll offer those patients SBRT as long as there's no documented ulceration of the tumor into the stomach or the duodenum already on endoscopy. If they have good performance status, if the tumor is less than 5 centimeters. So I'd say those are the big things for whether it's borderline resectable or locally advanced. They have good performance.
What about the body structure of the patient?
Sorry?
What are the regarding the body structure of the patient? If the patient is too much obese and cannot hold the breath and use abdominal compression.
Yeah, you're right. So they do need to be able to participate in the setup. So here we favor a light inspiration breath hold technique. What I've found with the abdominal compression is that despite best efforts and that it's set up technically correctly, it's variable on a day-to-day basis. And so I favored the light inspiration breath hold. So I do practice with patients in the consult. Can they hold their breath for about 20 to 25 seconds? But they have to do that about 10 times. It's not an exclusionary criteria. If they can't do light inspiration breath hold, we will do an abdominal compression, but you're right. They can't be, over the weight of the table, which here is like 400 pounds. They have to fit in the setup. So, and have to be able to follow commands as well. But so performance status, ability to participate in treatment, tumor less than 5 centimeters, no documented ulceration on endoscopy. And I would say another one should be that there's less than 50% of the tumor is in contact with the small bowel or stomach.
Yes. Yes. Yes, thank you so much. I think it was I learned a lot. It was very useful for us.
Great.
And it was a very comprehensive lecture. Thank you so much.
Of course, and if you have questions going forward, you have my contact information, so feel free to reach out. Always happy to help, especially if you're thinking about starting this at your center. I'm always happy to chat about that.